What's up, guys? It's your boy, C Money, C Dog, coming at you with another banger. Today, we're going to talk about ventricular assist devices. Now, this can be pretty scary to have as one of your calls as a paramedic. So, we're going to break it down into a few things that I really want you to know. One, we're going to talk about what is it? What is a ventricular assist device? Down to the basics, right? The next thing that I really want you to know is what do you need to know, right? There's a lot of information, a lot of things, and a lot of tricky stuff that can be wrong with this thing. Also, we need to talk about what can happen. These devices are surgically implanted, and so there's a lot of tricky things that can happen in our care that we need to know about. And also, we need to know how to address. So let's get into it. Let's talk about a few things with the ventricular assist device. So let's talk about it for a second. Here's our beautifully drawn heart. We got the four chambers, we've got the ascending aorta, and some other vasculature there. So basically, a ventricular assist device is assisting the ventricles in doing their job. It's not really taking anything over. What it is just kind of turbocharging some blood out of the ventricle and throwing it back into the aorta, right? So it's just assisting. It's not taking over. It's not making the heart relax. It's just assisting. And like I said earlier, this is a surgically implanted device. So it's implanted into a ventricle, whether it be the left or the right, or both. And this is just a mechanical pump, something that constantly is spinning around, generating pressure in the ventricle. And like I said, this isn't taking anything over, but rather supporting the blood flow from the ventricle. So it's taking some extra blood, it's diverting it out of the normal pathway, and it's sending it through the aorta with a little bit more pressure. Now, there's a few different devices that we can encounter in the field. Long pause. My hand hurts. More common that we see is the LVAD, or the left ventricular assist device. There also exists an RVAD, or a right ventricular assist device. And if there's a left and a right, there's got to be a BiVAD, or both the left and the right ventricular assist device. Now, there's a few less common that we're likely to see in the field. This is more in the critical care setting, or transport, or ICU setting. So an Impella is a ventricular assist device, but it is not surgically implanted. So this is something that's percutaneous, that's done into the vasculature, and sort of a temporary means to ventricular assistance, not something that's implanted. Now, this is typically a bridge to an LVAD, or to transplant, or to ECMO. We also have a total artificial heart. So, you know, kind of, sort of a ventricular assist device, only it is a total artificial heart. So there's not really any ventricles to do the pumping. It's doing a lot of the job for it. Some people say that venous arterial ECMO is another example of ventricular assistance. Eh, kind of. But VA ECMO is assisting that by kind of giving the heart a break. And with venous arterial ECMO, it's also kind of negating the pressure needs that the ventricle needs to do. So there's a few types of ventricular assistance devices and what they do. Now we can better understand that moving forward. Oh my gosh, how long of a pause did I need here? So I know you're thinking, man, I kind of understand it, but uh, like, what? How does it really work? Well, let me tell you. I'm gonna break it down to you like my favorite fast food restaurant. The way it works, the way LVADs work, is like McDonald's. So think of your favorite McDonald's, right? Mine is just 5 minutes away from my house. It's amazing, right? Now, the fast food workers have to sell hamburgers, right? They need to sell these hamburgers because that's what their job is relying them to do. So they need all these hamburgers, and there's a huge line in the drive through. They want to sell these hamburgers. They need to sell these hamburgers. But typically, what's the problem, right? The drive through is too long. So this drive through is backed up, and they're just not pumping these burgers out like they need to. There's a huge demand for the burgers. They're just not able to get the burgers out like they're supposed to. There's a backup in the drive through. So, what happens? Well, a handy dandy worker comes in. He's like, "Hey, I signed up for some overtime. I'm going to be able to help you out and, help with the drive through situation." So he's going to open up another drive through lane, and he's really fast at taking orders. And he's going to say, "Hey, I can take some orders over here." Now, cars are going to come flying through his lane because he's so fast at taking orders and dishing out burgers. So, with this open lane, he's super fast at doing it and super efficient. We can start slinging them cheeseburgers way more faster. Think of LVADs like this, it's opening up that second drive through line to help get those burgers out. Now, there's some key components that we have with the LVAD. Pictured here, you can have somebody with a left ventricular assist device. A few things you're going to want to take note of. One, hanging on the belt or waist is a controller. Now, typically, what's implanted now is the HeartMate 3. So, look for the controller. That's the actual thing. Maybe it's making alarms at you, anything like that. That's the controller. Close by and attached to that controller should be some batteries, should be two batteries somewhere along the waist. You've got those two wires that are going to the batteries, and then you've got a third wire that should be implanted into the patient's upper abdomen or chest. Now, that's the drive line. That is the line connecting the LVAD, the actual pump, to the controller. And then where you won't see on your assessment is the actual implanted LVAD. That's going to be the implanted device on the ventricle, the left ventricle pictured here. And this is kind of the anatomy of that LVAD. Let's talk about a few things that can happen with LVADs. So, some pretty scary stuff that can happen when we're talking about LVADs. So, um, few common things as we're kind of assessing patients and looking for things that can go wrong with them. Um, Most commonly, they're disconnected from their power supply. Either their batteries ran out, or they got disconnected, or they lost power in their house. This is a common issue that we see. To mitigate this, we want to hook them up to batteries. They should have a sack with them that has additional batteries. Next, a driveline failure or a disconnection in that driveline. So check the driveline connection going from the LVAD to the controller. And now, if that connection's fine, you may have to kind of maneuver that inside the patient's chest or abdomen to make sure that the connection's solid. A controller failure, so the actual thing on the waist failing. Hopefully, they have a secondary controller. Otherwise, there's not much else that we can do for that. And embolus formation. So, commonly, these patients are going to be prescribed uh, some sort of anticoagulants to kind of help mitigate those embolus formations that we may see. So, there are some assessment considerations that we want to take into account when we're taking care of an LVAD patient. I want to ask you a question. Do you think that this person is going to have a pulse? Your answer? Well, since there's no pulsatile flow with an LVAD, it's a continuous pressure building of the assist device. Sometimes there may not be a pulse present. Now, depending on how well that person's left ventricle is functioning, you may be able to feel a pulse. But in some cases, you may not have a pulse. So, how can we assess perfusion with someone with an LVAD? Pretty easy. One, assess that capillary refill. Assess the distal perfusion, the skin and the fingers, to get a good picture of their perfusion. Sometimes automatic blood pressures won't be accurate, so manual blood pressures is the way to go. Skin condition and mental status are also a great way to assess perfusion in somebody. That kind of gives us a good picture that their heart is pumping the rest of the body to make sure that they're getting the blood that they need. Now, beyond just assessing the patient and their perfusion status, we also want to perform some mechanical checks. One of the first things that I like to do assessing with LVAD patients is listen to their heart. Now, we can see some underlying heart tones, but of course, we're trying to assess the functionality of the device. We should hear a mechanical whirring or some sort of buzzing sound to make sure that the LVAD is functioning. On top of that, we also want to assess the exterior LVAD as well. So make sure that the batteries have enough charge during your care time. Check or listen for some alarms, whether they're low flow or low power. Check for those alarms on the controller to make sure that there's nothing going on and nothing that you can anticipate happening. Check all the connections that are on the LVAD and make sure that everything is secured tightly. And if you haven't done it already, if you're taking care of this person and they need to be transported to the hospital, you need to call the ventricular assist device coordinator. This person is going to help guide that patient care so that if you do have questions or treatment concerns or something like that, patient specific, we really need to call that person to help guide our treatment and to see what this person needs specifically. Now, CPR. Let's say this person does not have a pulse, they're unconscious. You've done treatments to resolve this and they are unconscious. In that case, CPR is likely to dislodge the ventricular assist device. Whether it's an L or RVAD or BiVAD, doing CPR should be the last thing we do for these patients. In general, make sure you're using common sense when assessing these patients and asking them how they normally present if they're able to. Now let's talk about some other things that can happen with these LVAD patients. So, again, more than likely, because of how stagnant blood flow can be with an LVAD patient, there are going to be prescribed blood thinners more than likely. So, stroke or embolus formations is going to be super common. And this can happen with LVAD patients. Next is aortic insufficiency. So, sometimes that aortic valve may not have enough pressure, and that non opening of the aortic valve can happen. Because of that, um, yeah. Next is right heart failure. Of course, What's the more common cause of right-sided heart failure is the left-sided failing. So typically causing that pulmonary hypertension or acute pulmonary edema, pump thrombosis, so actual clotting in the pump due to some inadequate or unprescribed anticoagulation, or a low flow state. So if that alarm is saying low flow, could be something like that. Driveline infection, so some sort of infection with the implanted driveline. And because of those anticoagulants, GI bleeding is definitely common. With LVAD patients, do a thorough assessment. Make sure that you are looking for not just the patient's presentation, but also the device and how they're presenting.